Good afternoon, everyone, or I suppose by now it's good evening. Welcome et bienvenue à notre session Sleep and Dementia Risk for Women. It is a webinar organized by the Dementia Society of Ottawa and Renfrew County. We're so pleased that you could join us tonight, and we would like to start our evening with a land acknowledgement. The Dementia Society of Ottawa and Renfrew County acknowledges the privilege to be operating on the unceded traditional territory of the Algonquin Anishinaabe. The people of the Anishinaabe Algonquin Nation have lived on this territory for millennia. Their culture and presence have nurtured and continue to nurture this land. The Dementia Society honors all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Monique Doolittle-Romas, and I have the privilege of being the CEO of the Dementia Society of Ottawa and Renfrew County. And I will be your moderator for this evening, but I am not your guest speaker. With every webinar, we always have some reminders for everyone, but I would be remiss if I didn't mention that Tuesday will be Giving Tuesday. And if you find our work helpful, if you've benefited from the support of our dementia care coaches or these education sessions, we would encourage you, if you can, to support the Dementia Society through a donation at dementiahelp.ca/Giving Tuesday. We would encourage you also to volunteer and help us spread the word that we are here to support caregivers. Thank you so much. Why are we hosting a Women's Mind Matters webinar series? We know that women are disproportionately affected by dementia in terms of diagnosis. Women are 2 times more likely to be diagnosed than men over the age of 65. And for caregiving, 70% of family caregivers are women, and 80% of paid caregivers are women, and many of them are working at lower wages. We are here and we host these sessions to help provide insight and to empower women to take measures to delay and prevent dementia when possible. We're so pleased that you could join us this evening. About our process for this evening, a reminder that we are recording this session this evening. It is also being live cast on Facebook and recorded for future demand viewing. And we do know that our YouTube channel is very popular. Everyone but our speakers and event coordinators are muted today. We encourage you to pose questions in the chat function of either the Zoom webpage application or on Facebook comments, and we will do our best to answer as many questions as possible at the end of the webinar. For your own privacy, please do not disclose personal medication, health or medication information. Any medical information shared in this webinar is for information resource only and is not to be used and relied upon for any diagnostic or treatment process. This information should not be used as a substitute for medical professional advice, diagnosis, or treatment. Si vous avez des questions, s'il vous plaît, n'hésitez pas de poser vos questions en français. On va s'assurer de faire la traduction et de partager votre question. There's increasing interest in dementia prevention in our community, and specifically understanding the connection between sleep and brain health. And as we head into the holiday season, we're busier than usual, and we know that that can impact our sleep as well. So this evening, for the next hour, we will explore the critical intersection of sleep and dementia risk in women. To do that, we have an expert with us tonight, Dr. Laurel Charlesworth, MD, FRCPC, sleep physician and neurologist, the Ottawa Hospital, assistant professor of medicine, University of Ottawa. And now I turn it over to our expert, Dr. Charlesworth. Welcome and thank you for joining us this evening.
Thanks so much for having me. I'm really pleased to be here and very happy to be sharing this really important topic with everyone. So I'm going to share my screen here. So that should have shown up there. So it's a bit of a hefty talk. So I've tried to distill it down into some salient points. So the objectives of the evening for us today are to review the role of sleep in brain health, including the impact of good sleep habits and risk associated with poor sleep, and apply practical, actionable tips with really emphasis on actionable. I'm hoping that this will be a very down-to-earth type of talk. I would like to reiterate for the questions at the end, please try to avoid personal health information. But when it comes to sleep troubles, what one person has, a lot of people experience. And so general questions are very welcome. Information is intended for informational purposes, not medical advice. And then specifically for this talk, just to mention that when I refer to women, it's generally referring to the studies and therefore someone who is assigned female at birth is typically what is used as women in these studies. So that's just a note about terminology. My only disclosure is that I receive some contract funding from Transport Canada, but I have no other public or private industry disclosures. So briefly, I would like to start off with some sleep statistics, which is that we are a chronically underslept society. We should be spending about a third of our lives asleep. But most people don't get to experience quite that much sleep, unfortunately, with various demands. And so the recent Statistics Canada release from 2022 suggested that 1 in 4 people under the age of 65 are not getting enough sleep. And only 61% report high quality sleep, whereas over the age of 65, that drops even further. 1 in 2, or I guess raises even further. 1 in 2 are not getting enough sleep. So sleep loss really is kind of an epidemic. In 2007, sleep deprivation was declared a probable carcinogen by the World Health Organization. And in 2019, sleep disorders and insufficient sleep was declared a public health crisis by the Center for Disease Control. And so more and more evidence is building that poor sleep has consequences and can be bad for our health. So poor sleep can be directly associated with heart attack and stroke, metabolic syndrome, including things like obesity and type 2 diabetes, as well as mood disorders like depression and anxiety. And when it comes to sleep, we often separate sleep schedules and circadian habits from sleep itself. And so circadian misalignment, commonly thought of as shift work, but there can be other things that lead to this, is also associated with cancer, colorectal, breast, liver, among others, heart attack and stroke, traffic accidents. And then these are some of my favorite stats because they're just kind of silly and fun. Slower marathon times are associated with circadian misalignment, and ER visits in pediatric ERs for trampoline accidents are also associated with circadian misalignment. So some really big things, but also just some small things in day-to-day life that sleep and circadian changes can affect. And as I'm sure you're probably aware, this poor sleep epidemic is becoming more and more important in the public attention. These are just some articles that I've pulled out emphasizing the dangerous effects of poor sleep. And this is kind of everywhere these days. And on the one hand, it's great that we are acknowledging the importance of sleep and the dangers of poor sleep. And yet there seems to be a relative paucity of tips and solutions for how to improve your sleep. So that's really going to be part of the talk today. Is I really want to emphasize, despite all of the things that I'm going to be telling you about, despite all the risks and the scary things, don't panic, because there's a lot of things that we can do to help our sleep. And if we can't, a lot of these things are correlational. And it doesn't mean that just because somebody is sleeping bad that they are going to have a negative health outcome. So I really just want to emphasize that. There's a lot of scary things, but it's not all doom and gloom. I'd like to start with a little bit of sleep physiology. So just sleep in general. What is sleep? We know that humans need about 8 hours of sleep. You've probably heard that before. The average, it's a bell curve, kind of like this, is about 7 to 9.5 hours. And I think it's really important to acknowledge that this is a bell curve on both sides of the 8 hours, because a lot of us think that we can get by on 7.5 and 7 hours. But it's equally important to acknowledge that as many people are on the 7 to 7.5 side of this curve, there's many people on the 8.5 to 9 hours. And so this is a lot of what's leading to that chronic sleep deprivation. It's incredibly uncommon for somebody to truly get by on less than 7 hours of sleep. And they've done studies to look at reaction time and processing memory, et cetera. And even people who think they do okay on less than 7 hours do not. So really that 7 hours seems to be the cutoff. There's a very rare genetic mutation that allows people to get by on low sleep. And I'm very jealous of them as a 9-hour sleeper. So very important to acknowledge that some people do need more sleep. In general, women need more sleep than men. This is a bit of a challenging metric to determine, but in general, women sleep more, nap more, and are more tired when they lose sleep. The range is anywhere from 11 minutes in a fairly large study up to 45 minutes to an hour. So something in a range there. In general, women do need slightly more sleep than men. We break our sleep up into different sleep stages that are staged according to brain activity. So N1 sleep, so this is split into non-REM and REM. N1 sleep is the first stage of non-REM sleep, and that's this at the top here. There's some slowing, somebody's drowsy. This is the type of sleep that you might slip into when you're at a boring lecture, or when you're in the weight room, maybe waiting for your physician, or after a nice warm lunch, whatever it is. This is kind of that first drowsy state of sleep when somebody may even still retain some awareness and some memories. N2 is the sort of the meat of sleep. Most of our sleep is N2 sleep. And this is where we get some really nice sleep structures. The brain is very active here. We don't have a great idea of what it's doing, but it's very active. N3 sleep, we also call our deep sleep. It is our delta sleep with these big, large waves. So networks of the brain are just going in unison. And we'll talk about that in a second. REM sleep is the dreaming sleep. The EEG of REM sleep almost looks like wake. It's a little bit quicker. This is when you may replay things of the day or play random images that your brain interprets as dreams. And it's associated with rapid eye movements, and generally associated with complete body paralysis, because if your body were not paralyzed, you would act out your dreams, which is a sleep disorder called REM sleep behavior disorder. So in general, associated with paralysis. Now back briefly to non-REM sleep, the N3 deep sleep. So this was an exciting breakthrough. I think the first paper came out in around 2015. And this new system of waste clearage was discovered in the brain. We call this the glymphatic system. So it's like the lymphatic system, but the glymphatic system of the brain. And essentially it's this complex network where you get this efflux of fluid that basically pulls toxins from the brain. And we know that this is associated with clearing amyloid beta, which is an important protein involved in the development of Alzheimer's disease. As well as there are associations with recovery from concussion and mild traumatic brain injury. There's associations with multiple sclerosis and other inflammatory conditions. So it's this really important system, and it's activated by N3 sleep. This was a brilliant paper that came out a few years ago where the red is the blood flow, and the blue here is the pulsation of the CSF. And actually this flow that's causing this efflux and this clearage of the waste is locked with N3 sleep. So deep sleep is very, very important in clearing cellular waste and important in the genesis of neurodegenerative conditions like dementia. So N3 sleep, very, very important. And there's some evidence that women do get a bit more N3 sleep than men. Now, the relevance of that, we're not incredibly sure, but just some differences there in sleep stage and the importance of the different sleep stages. Now, with healthy aging, there are some changes that happen to these sleep stages. So REM sleep, the dreaming sleep, proportionally is maintained throughout healthy aging into older life. In patients with neurodegenerative conditions like dementia, REM sleep seems to fall off a little bit earlier. We don't exactly know why, possibly due to sleep fragmentation. As we get older, our sleep does become more fragmented. So this is an example of a young adult who has these nice sleep stages down through non-REM, back up to REM, up and down throughout the night with some very brief awakenings. Whereas this is the more typical type of pattern that may be seen in an older adult who has a bit more trouble maintaining that constant sleep. And that's likely due to a combination of networks in the brain, as well as accumulation of other medical conditions, pain, perhaps maybe a need to get up and use the washroom multiple nights or whatever it is interrupting the sleep. So that's what we can see with aging. Now, N3 sleep, that really important waist-clearing sleep we just talked about. This is an example of a young person's N3 sleep, nice, big, broad delta waves. And as we get older, these delta waves become a little bit smaller and a little bit less powerful. Now, part of this is likely because the brain pulls away from the skull a little bit, so it just looks less large. But there seems to be a decrease in the power of the N3 sleep as we get older. In addition to sleep and sleep-wake cycles, it is important to also mention what we call chronotype, which is the intrinsic circadian rhythm. Now, the circadian rhythm, people think of circadian rhythm being sleep because that's what really differentiates our day-to-day cycles for most of us. But other things in the body independently follow circadian rhythm, like body temperature, food intake, social cues, physical activity, blood pressure, can all follow a circadian rhythm. And this is just kind of a fun, quick story. Jean-Jacques Dorteau de Marin was a French biologist who first discovered circadian rhythm from these heliotropic plants that they were raising and lowering their leaves with the sunlight, and he put them in a closet away from the sunlight, and they kept on raising and lowering their leaves. And he realized that this is some sort of an internal cycle that's independent of light exposure. So he was the first chronobiologist. And we know that all animals on Earth, and plants actually, not just animals, have a circadian rhythm, whether they're nocturnal animals or diurnal animals. Everyone follows this type of rhythm. But there are some differences in someone's circadian rhythm. So as we get older, that length of a day shortens. And so older adults are more likely to experience like the morning lark phenomenon, or what we call an advanced sleep-wake phase. This is the opposite of the teenager phenomenon, which is a delayed sleep-wake phase or night owl, where teenagers like to stay up late and sleep in late. And it's not just sort of the trope of the lazy teenager, it's truly what their body rhythm is doing. And the opposite happens as we get older, as that rhythm shrinks. And as we get older, we prefer more earlier bedtime and earlier wake time. And in some people, this can get to the point where it's almost pathologic. They cannot sleep in past a very early hour, like 4 a.m., 5 a.m. And that at that point where it becomes impactful on day-to-day activities, that's when we start to call it a disorder if it's bothering them and if it's impacting their daily life. So that becomes more common as we get older. There are some ways to manage this with evening light and circadian management, and this is something that we do in sleep medicine. I wanted to note briefly about smart devices. This is a question that I get a lot in clinic because everyone has, well, not everyone, lots of people have smart devices these days, Apple Watch, Fitbit, Garmin, whatever they are. And so I get asked a lot, well, my Apple Watch says that, I'm not sleeping well. What should I do about that? And I think it's really important to acknowledge that these are consumer devices. And so their prime objective is to get your attention. Their secondary objective is to get health data. And so the algorithms in the device that get people to check them more are going to be the algorithms that are chosen. So it's really important to have a big grain of salt when you're thinking about the information you're getting from your smart device. They are improving over time. They seem to be reasonably reliable with total sleep time. If it tells you sleep this amount, you probably sleep that amount. With the one major caveat that if you're moving a lot, if you're just somebody who's a bit more mobile in the sleep, it'll underestimate it and it'll give you false numbers. It's pretty unreliable for deep sleep, REM sleep, oxygen saturation, and sleep quality. Apple Watch seems to be the one of the lower ones, but really Garmin and Fitbit, they all have quite significant limitations here. So it's fun to track. I love when patients ask about it because it just shows that they're more engaged in their sleep and they're enjoying following these metrics, but use with really great caution because these are consumer devices. Specifically to sleep and gender. So that was kind of sleep in general. There are many elements of sleep that are quite unique to women. And as with almost all areas, I would even go so far to say as all areas of medicine, right? Medications are tested on men, studies are predominantly men, right? A lot of things are male-centric in medicine. And so a lot of these studies, the data that we have is very male-centric. So there are some specific things that we know about women and sleep. There are higher rates of some specific sleep disorders. So women are 2 times more likely to experience symptoms of restless leg syndrome, especially premenopause when iron stores are lower. It's very much associated with restless legs, as well as fatigue and periodic limb movements. Women are much more likely to experience insomnia. And then there tend to be greater social demands on women as well. You may have heard of the second shift, which is the idea that the woman comes home from work and then is managing the household. Well, this is the idea of the fourth shift, they were calling it in this paper, which is essentially that the second shift becomes the third shift and the fourth shift when the woman is providing emotional support for family members at night, or maybe even caregiving activities for older adults or whatever it is. Disproportionately tend to fall upon women. So that can have a negative impact on women's sleep. Premenopause, the menstrual cycle, can have effects on sleep quality. There are hormonal influences on sleep architecture. And the menstrual period itself can interrupt sleep. Pregnancy and postpartum, I put as a single point here because I think everyone knows that affects everyone's sleep. So we won't belabor that one. Perimenopause, mood changes and hot flashes can affect sleep. And then in menopause, there are higher rates of obstructive sleep apnea as estrogen and progesterone levels fall. And oftentimes this can go unrecognized. Again, kind of coming back to a lot of the studies, we think of sleep apnea being heavy snoring, stopping breathing, and daytime tiredness. And we know actually those are much more common symptoms in men, whereas women tend to be a little bit more subtle with their symptoms. The snoring might not be as prominent. The daytime sleepiness might be something that they can kind of push through, or they tend to ignore. Whatever it is, and not bring to medical attention. Whatever it is, it can be a little bit harder for women to seek that diagnosis. So it can go undiagnosed. We're going to spend a little bit of time talking about sleep-specific disorders. So this was a fairly large study that came out recently that looked at sleep duration and development of dementia and death. And this is, like I said at the very beginning, this is a scary thing, but important to acknowledge and a big part of this talk, which is that people who sleep less have a higher risk of developing dementia and ultimately mortality over subsequent years. The risk seems to be somewhere between 30% to 100%. It's a bit hard to really break down those numbers, but there is an elevated risk of developing dementia with lower sleep time. So I'll point out here, it's the less than 5 hours. So these people are very sleep restricted. 6 to 7 hours, 7 to 8 hours are these lines at the top, where, naturally over time, people do succumb to natural aging, but much quicker for people who are sleeping less. I'll also point out that people who are sleeping a lot more are also on this larger curve here. Daytime napping in the study was also associated with higher risk of dementia and higher risk of mortality. Now, really, really important to acknowledge that this is a correlational study. And this is the typical example that, when we're in our undergrad first year classes that we learn about. So when we're talking about correlation, ice cream sales correlate with drownings. That does not mean that ice cream causes people to drown. So when we're thinking about a study like this, well, why is somebody sleeping less than 5 hours? Usually there are other contributors. There's some pain, life stressors, socioeconomic factors. They're working 2 jobs. They're caring for multiple people, whatever it is. So there are lots of other factors that can contribute to development of dementia and potential mortality. It does not mean that sleep is causing that. The other thing is that we know dementia and neurodegenerative conditions really start to have their earliest signs 10, 20, 30 years before the person comes to medical attention. So it's possible that in these types of studies, when we're looking at broken sleep, a portion of that are people who are already showing early signs or symptoms. So it's really hard to break this in to say poor sleep causes dementia. We know there's an association, but it may not be quite as simple as that. Sleep disorders become more common in everyone as we get older. Part of this is secondary. So as we get older, we tend to accumulate medical comorbidities, so medical diagnoses, things like urinary issues, prostate issues, especially in men getting up multiple times in the night to use the washroom, or women after multiple births maybe need to use the washroom more times at night that can wake them up. There's a lot of issues with chronic pain that can wake people up. So lots of these things tend to accumulate as we get older and can impact sleep. Primary sleep disorders, though, increase as well. So obstructive sleep apnea and snoring get more common as we get older. Movement disorders like restless legs or periodic limb movements where the legs kick and move in the night become more common as we get older. Most parasomnias, like sleepwalking, become less common as we get older. But this particular type of parasomnia that I mentioned when we were talking about REM sleep, so REM sleep behavior disorder, where people act out their dreams, becomes more common as we get older. Daytime sleepiness and daytime fatigue becomes more common, and circadian disorders, like we talked about. Specifically, so moving on to sleep disorders and specific dementia risk, obstructive sleep apnea does seem to, people with obstructive sleep apnea are more likely to develop mild cognitive impairment and dementia. And this is one area that has been specifically looked at in women, and the signal seems to be much stronger. So women with obstructive sleep apnea are much more likely than their male counterparts to progress to experience MCI and dementia. REM sleep behavior disorder, that dream enactment, is strongly associated with Parkinson's disease and is specifically associated with a higher risk of developing Parkinson's disease dementia. Now, this is a very long time frame, so the development of the condition predates the diagnosis of Parkinson's by at least 10 to 15 years in most cases, but there is an association there. Patients with insomnia earlier in life, really thinking early to middle life, patients are higher risk to develop dementia later in life. Restless leg syndrome, I mentioned, there's no definitive associated risk with dementia, but it is associated with insomnia and cardiovascular disease, both of which can have negative effects on long-term cognitive health. Mentioning insomnia, I think it's really important to talk about insomnia medications. There have been a couple of very large reviews that have looked at people who use these medications long-term. So nearly all of these medications are on label, as in they've been studied specifically for short-term use. Now, in the general population, these are medications that we often use on the longer term, but it is off-label. And there is an association in patients who use these medications long-term with ultimate diagnosis of dementia many decades later. This has been especially shown in patients with benzodiazepines. Again, I think it's important to acknowledge that correlation and causation. Why aren't people sleeping in the first place? There are many things that contribute, but there is an association. It's important to acknowledge the gold standard treatment of insomnia is cognitive behavioral therapy. Insomnia actually responds best to behavioral approach and therapeutic approach as opposed to medications. And that's something in Western medicine that we often forget, and we kind of jump to medications. But actually, this is one area where a non-medication approach is best. The best approach is with a trained therapist, psychologist, or psychotherapist who's trained in sleep medicine. But there are some really good options that people can pursue independently online. There's some good websites. There are really good books, and there are mobile applications. I'm happy to put some resources in the chat if that would be helpful. I should have prepared something in advance. Happy to provide some evidence-based recommendations. And some cities will have group therapy for cognitive behavioral therapy as well. So for example, in Ottawa, we have at least 2 group therapy options that is OHIP covered. So people can pursue that if they aren't able to access a private therapist. I also put in a word about melatonin here. We're talking about insomnia medications. I figured that this would come up as a question. So melatonin is not a sleeping sleeping pill. It's not a sleeping chemical. It is a circadian chemical. And like I said, sleep and circadian biology are very different things. Sleep follows circadian nature, but it's not the same. And actually, melatonin is recommended against as an insomnia medication. It should not be used for insomnia. Now, it often is because it has a relatively low risk profile. It's not as sedating. It doesn't cause the major side effects of the other things, but it's not quite the simple thing that oftentimes people think it is, and that you'll read online and see in posts. The other thing that's important to mention, at least in Canada, it's a health product. It's not a prescription medication. And so the dose that you get, there's a nice study out of Guelph, is anywhere from about 86% advertised to 476% advertised. So you don't quite know what you're getting with melatonin. It has a role, but just to be used carefully. And if somebody is going to be using melatonin long-term, they should be speaking with their physician to make sure that it's being used appropriately. When used, we often forget about light. So light suppresses melatonin, and light is almost the other side of the coin. And when I'm speaking with my patients, I often liken it to the bookends of sleep, light and melatonin. So melatonin is like this flimsy little bookend, you know, that one that doesn't hold the books up. And light is like this heavy bookend that actually works really well. And so if we're thinking about melatonin, we should be thinking equally about light and using light in a rational way to help with sleep. Final slide on anxiety, I promise. So there's this new phenomenon called insomnia anxiety. And this is somebody who has a bit of insomnia, but it's not the insomnia that's a problem. It's their worry about what the insomnia is doing. And this is coming back to that first slide where there's all this panic about, you know, what we are doing to our bodies by limiting sleep, but limited guidance for how to improve your sleep. And this has led to this phenomenon of, understandably, people becoming really, really worried about their sleep. The best analogy that I've heard that I like to pass along is the analogy of appetite. And when somebody has poor appetite for a day, maybe even a week, just things kind of are down, they don't worry. They don't worry that they're going to waste and wither away by not eating. They know the appetite will come back, and eventually maybe they are more hungry than usual, and appetite will ebb and flow. And we tend to not worry quite that much about appetite moving day to day. Insomnia and sleep is the same way. Of course, if you're not sleeping for many, many days and weeks at a time, that's concerning. But if somebody doesn't sleep for a single night, sometimes what can happen is it provokes this cycle of them getting worried that the next night and the next night, and oh my goodness, I'm going to develop dementia. I watched Dr. Charlesworth's talk, and it's okay because night to night, people will experience some level of ebb and flow of their sleep pressure. And so if somebody's experiencing insomnia, anxiety, this is something that sometimes can be helped by a type of therapy called acceptance and committance therapy. So this is where somebody works on the fears that are leading to the insomnia, anxiety, as opposed to the insomnia itself. So it's this interesting secondary health phenomenon that's come from greater health awareness. So we talked a lot about how sleep is associated with dementia. Well, what about sleeping better? There are some studies that improved sleep can improve cognition on the short term. So people who improve their sleep quality have shown some minor improvements on things like attention, vigilance, and memory. And these are relatively small and not the most robust studies. This was an interesting one. So patients with a genetic risk of Alzheimer's disease, so they don't have Alzheimer's, but they have the ApoE4 allele, which is a genetic risk of somebody developing Alzheimer's disease. So these patients at high risk, patients who sleep better, they are more likely to clear their amyloid beta. So there's actually CSF evidence that they are clearing those toxins, and on pathology, on autopsy postmortem, they have less amyloid accumulation in the brain. So there is some evidence that improved sleep quality can help with the risk of developing dementia. Patients who have obstructive sleep apnea who use CPAP have lower risk to develop MCI or dementia compared to their OSA counterparts who don't use CPAP. And there's some limited evidence that even in patients who don't have mild cognitive impairment or dementia who use CPAP may have better cognitive outcomes. So there may be some benefit to treating sleep disorders when it comes to cognition as well. And then this was a study, unfortunately, the results aren't released yet, but I'm excited for this one. So this was a protocol that was published recently where they were specifically looking at cognitive behavioral therapy, so that treatment for insomnia that I was mentioning, and the effects on clearing the amyloids, the toxins from the brain. So this is an ongoing study out of the States, and so we eagerly await those results. Can CBTI help? Specifically in patients who have dementia, sleep can be really challenging because it becomes quite dysregulated. So that circadian cycle can become very, very dysregulated and irregular. So some things that can help are to really focus on non-pharmacologic treatments. So sedating medications and sleeping medications can cause harm. Sometimes they are required, but have to be used very carefully. It's very helpful to encourage physical and social activity during the day and to avoid napping. One of the prominent issues with patients with dementia and their sleep is that the lower stimulation during the day, they can sometimes nap, and then they get what's called day-night reversal, where they're sleeping a lot in the day and really active at night. And that can be a challenging cycle to get out of. There is some independent evidence that bright light can help with circadian rhythm and mood, which has been demonstrated individually in patients. There was one study looking at patients with Alzheimer's disease and another study looking at Parkinson's. So bright light, kind of thinking of it on that flip side of the coin as melatonin, light can be a powerful treatment when it comes to sleep and mood. So how can someone sleep better? So I'm going to give you some rapid fire tips of general approach to sleep. Now, this is somewhere along the lines of sleep hygiene. It's best if somebody can have a consistent sleep schedule, including weekends. So people should really be sleeping at the same time, bed at the same time, wake at the same time, with no more than 1 hour difference will really help with sleep consolidation. Making sure someone gets sufficient sleep. So I mentioned at the beginning that really we should be targeting between about 7 to 9 hours of sleep. And we are a chronically sleep restricted society. And so just being very mindful of the things that are taking the place of sleep, whether it's staying up to watch the news or pushing sleep off to be able to go out for drinks after dinner or whatever it is. We tend to sacrifice sleep in favor of social or occupational or family needs. And, you know, there's a level of that is inevitable, but I think we should always be mindful of the sacrifices we're making when it comes to sleep. It can be very helpful to start a day with morning light. So in the summer, wake up, open the drapes right away. And in the winter, when it's still dark in the morning at the typical wake up time, having an external bright light can really help. And they make light up alarm clocks, or you can just purchase one that you turn on. Maybe you have it in when you're drinking your morning coffee or whatever it is. So bright light can really help with sleep consolidation the next night. So it helps cement that circadian cycle. It's important to limit caffeine intake. Now, I know this is in juxtaposition to other things that you may have heard about dementia risk, which is that caffeine intake has been shown to be associated with lower risk of Parkinson's and Alzheimer's. So it's really a balance, right? That's everything in medicine. We get some conflicting results. I would say from a sleep perspective, if somebody is having insomnia, they absolutely should not be drinking more than 1 cup of caffeine, and really caffeine should not be drunk after noon. Caffeine state, it has a half-life in the body of 5 hours, can be a bit longer in some people. And even in people who think that they don't get affected by caffeine, there are studies that show that it affects sleep cycles. So really important to be mindful of caffeine intake. Water intake is also important to be aware of, especially if somebody is waking many times in the night to use the washroom. There are many sleep-altering substances. Alcohol is one. Even a single cup of alcohol can affect sleep stages. So just to be very mindful of that. And if alcohol is to be consumed, it should be consumed several hours before bed so that it can be flushed out of the system. Marijuana, especially THC, but CBD to an extent as well, has effects on sleep structure. And nicotine is a alerting substance, kind of like caffeine. So it's a little shot of caffeine there. So these things can definitely affect sleep. Pain and other medical conditions can affect sleep. So in people who are experiencing things that interrupt their sleep externally, talking to the family doctor, physiotherapist, massage, whatever avenue works best, but addressing the underlying thing that's interrupting sleep. Napping during the day is challenging. In general, good sleep hygiene is to not nap during the day if a nap is absolutely required or enjoyed. I have a lot of patients who love their afternoon nap, and that's okay, but it should be limited because napping too much in the day will disrupt nocturnal sleep. So it really shouldn't be longer than about 30 minutes. Exercise for at least 30 minutes a day has benefits on every aspect of health, but especially sleep, and has been shown to be more effective than sleeping pills. So a great thing to target if possible. Avoiding bright lights and blue light, which is like your screens, 2 hours before desired bedtime. This suppresses melatonin. So it's good to have a natural rise in melatonin. A bedtime routine is very helpful. It sets your brain A warm shower in particular, if somebody's finding it hard to get into sleep, this tricks your body into thinking that your temperature is decreasing, and that triggers that signal in your brain to say, oh, okay, it's time to go to bed now. So a warm shower or a warm bath can be very helpful. Keeping the room slightly cool can improve sleep architecture. The body sleeps a little bit better when it's slightly cool. The bedroom is sacred. So try to leave your bedroom for sleep and intimate activities only. We shouldn't be doing things like work or TV or things like that in the bedroom, because it dissociates the idea of the bedroom being relaxing and restorative. It's a good idea to keep clocks out of the bedroom. This is a controversial one when I'm talking to my patients. This is a hard one to do. But ultimately, so a lot of people wake up and check the time. And ultimately, that often doesn't make a difference. You have to wake up when you wake up anyway. But if you always wake up at 2 a.m., let's say you think you never get back to sleep if it's after 3. If you check the time and it's after 3, you're just not getting back to sleep. If you don't know what time it is, does it really matter? So removing clocks from the bedroom to avoid clock watching can be very helpful. And this is another controversial one as a dog owner, but pets in the room, especially cats, can be very challenging. And then what do you do if you cannot sleep? There's a lot of different things. Generally, it's best to remove yourself from the environment. You don't want to associate like a frustrating or negative environment with the bedroom. So if somebody can't sleep for about 30 minutes, it's best if they get up and remove themselves, do something really boring, fold laundry, listen to a non-stimulating podcast, not true crime. That's a popular one these days. Word search, whatever it is. Something that's just non-stimulating, boring, and then once somebody gets tired again, to head back to sleep. Mindfulness and meditation can help. And then this is a new one that I've been sharing with my patients recently. This is called cognitive shuffling. So this is a cognitive activity that can help people when they can't get back to sleep to distract their mind. So an example is you think of a word, and then for every letter of the word, you think of another word. So for bedtime, for example, we've got bird, elephant, dice, tea, ice, it rhymes, magic, and electricity. So that spells bedtime. But going through that process, you're kind of visualizing these new things. So that's one strategy. There are so many strategies that are available online and in some of these insomnia evidence-based resources. So lots of different things that can help. That's one that my patients have been particularly enjoying recently. And so then finally, when we talked about all this, when do you deal with your sleep yourself? And when do you talk to a doctor? I think it's good to know what some red flags are. With the bottom line being, if you are worried about your sleep, it is very reasonable to talk to your doctor. So someone should talk to their doctor if they are so tired during the day that they fall asleep in inappropriate settings, especially if it's not improved by increasing sleep. So some people, if they just sleep a little bit more, that improves things. That's usually a good sign that sleep's okay. But if somebody's falling asleep all the time, especially driving or anything dangerous, that's a red flag that they should talk to their doctor. If somebody wakes up many times in the night. Now, some people think they know why they wake up, and one of the most common ones is waking up to pee. Waking up to pee can be kind of a sneaky symptom of a sleep disorder. So that's one with a little bit of an asterisk. So somebody waking up many times in the night, even if they think they know why they're waking up, might be worth speaking with their doctor. If somebody snores heavily, gasps, chokes awake, wakes up short of breath, symptoms of sleep apnea, or even if somebody tells them they stop breathing in their sleep, they should talk to their doctor. If somebody's moving a lot in their sleep, especially if the movement disrupts them or their bed partner or has caused injury, they should absolutely speak with their doctor about that. And if somebody is experiencing low mood, low appetite, disinterest, anxiety, mental health symptoms associated with poor sleep, that is something they should probably talk to their doctor about as well. So some red flags there that, not all of these things mean that there's a sleep disorder, but it could be, and it's worth speaking with a medical professional. And that's everything. I think that was reasonable for time. So I'd be really happy to take any questions now. And we'll leave it at that. Thank you. Should I stop sharing my slides?
Thank you so much, Dr. Charlesworth. That was so interesting. And I have to admit, I'm a napper and I love my naps. So I will try to do better and limit it to 30 minutes. And that is actually related to the first question, which is a really, I think, relevant for all of us. If getting enough sleep is important, why is a nap bad as a path, or why is it a path to dementia?
Yeah, that's a great question. So, and this kind of comes down to the question of why is somebody napping? So, oftentimes naps are a sign that somebody's not getting enough sleep. So, it's likely not the nap that is dangerous. It's likely what the nap is treating that's dangerous. So that's an important acknowledgement to make. Now, one of the biggest issues with naps is just that it removes sleep pressure. So when you nap in the afternoon, it's a lot harder to get to sleep at night because you need that wake to push you into sleep when bedtime comes. And if you remove the sleep pressure by napping, it's much harder to get to sleep. Our nocturnal sleep is generally much better than any sleep in the day. So if somebody can get all of their sleep at night, that is going to be much more stable and restorative sleep. That said, especially when social pressures are changed, work obligations are changed, and there's less pressure to be awake during the entire day all in one go. Like I said, I have a lot of patients who love their afternoon naps, and if that is important to you, that is okay. But try to limit it and be very aware if there's an afternoon nap that's making up for nocturnal sleep. That's where you start to get a bit concerned that there could be a vicious cycle that's going on.
Thank you so much. I promise my naps are only on Saturdays. You mentioned the risk of taking sleep medications. Do you have any information on the risks of taking CBD as a sleep aid?
That's an area that we really need more information on. It's definitely something that's become more commonly used over time. It is challenging in older adults because there's some evidence that it can be associated with cognitive troubles and falls, and it isn't as well known in terms of safety effects and risk. Since it's not a in general, since it's not a prescribed health product, it's usually used by people over the counter, it's just inevitably going to be a bit higher risk. Now, that said, we have some early studies. CBD does, I believe it improves sleep onset latency, so it helps people get to sleep a little bit more at night. And it doesn't seem to have such negative effects on sleep architecture, but we just don't know. I would put in a word of caution about THC, the other main component of marijuana. We know that that is very challenging for sleep. It suppresses REM, it disrupts sleep. That one is challenging. And a lot of people use THC short term because it does have those effects on getting to sleep, but long term it can be very damaging. So THC we really caution against. CBD, my personal approach medically is usually to leave it up to the patient a little bit, caution about the potential risks, and offer alternatives. That's kind of my own approach when I'm helping my patients.
Thank you so much. Given that one is going to sleep at the same time, getting a half hour of exercise per day, and avoiding caffeine and other activities as well, what can we do to prevent waking up early?
Yeah, that can be a challenging one. There are some differences person to person. So first of all, if somebody's waking up really early, cannot go back to bed, and it's really disrupting their sleep quality, somebody should speak to their family physician about that, or their physician about that, because sometimes that can indicate that there's an underlying sleep disorder. Now, provided that that's also been assessed for, that the person that, sleep apnea has been assessed for and everything, then this could be a sign that it is a circadian disorder. And so addressing that with evening light to help push the circadian rhythm a little bit can be beneficial, can help with evening alertness. But I think the most important thing is to mention that sometimes that can be a subtle symptom of a sleep disorder. So step one is always going to be to talk to the family doctor.
Okay, certainly everyone is commenting. They would love to know the low-cost resources, online resources. I know you don't have time to enter it in the chat, but maybe if you could follow up with Herman, then we can send out the information to everyone who's registered. Somebody's asking about restless leg syndrome and what can they do to help get more sleep? Is there anything they can do?
I could go on that's an entire additional talk in itself. Restless leg syndrome is a medical diagnosis. So I think the easiest way to address that is to say to speak to the family physician. And this is something that is within the scope of practice of a sleep physician. So I have many, many patients with restless legs. There are so many non-pharmacologic and pharmacologic and lifestyle and everything approach that it would take me probably half an hour to go through everything. But I would say that it is a medical condition, so worth discussing with a sleep physician. There's great resources online. The Restless Leg Society is my favorite. I think it's rls.org for some more in-depth answers.
Wonderful. Private sleep labs, are they equivalent to the publicly funded hospital-based labs?
Yes, yeah. So it's a little bit complex with the way that OHIP works, but essentially the type of study that you get is going to be exactly the same. Like our hospital-based lab has some slightly higher level of monitoring that we can do that is only required in very, very, very specific particular patients. 99+% of everyone gets the exact same of what they would get at a private lab that is still OHIP funded, external lab versus in a hospital.
Okay, thank you. Lots of questions around light. I'm going to ask this one. When you mention light, evening and on waking, is that full spectrum light, like a SAD light that we often refer to, specialized light, not just a bright LED fluorescent incandescent light?
Exactly. So the SAD lights are generally dosed based on their luminosity or their lux. So what defines a bright light is a 10,000 lux light. And that's usually defined by how far away from you it is. So often it'll be 10,000 lux at 18 inches. There is just general spectrum lights actually can be used as well. At one point, I tried to do the math of exactly how to get an over-the-counter light, and it's really complicated. And these days, SAD lights are relatively affordable. Amazon has them, I think. I don't endorse Amazon, but as an example, about $30. For kind of the very base model. So it's generally easiest to get one of the formal SAD lights, and a SAD light is exactly what we use for circadian lights as well, because it's that 10,000 lux that has the evidence.
Wonderful. And it's good to know that you can buy one at a reasonable price, $30 with Amazon.
Yeah.
There's a specific
Quote me on that, but I think I think I've seen.
We promise not to come back and talk to you about it. Is there anything anybody can do to deal with the symptom or sleep apnea? How do you know if you have sleep apnea?
The only way to know definitively if someone has sleep apnea is to have a sleep study done in a sleep lab. And that's essentially where somebody is hooked up to so many wires. So we look at sleep stages, we look at breathing, we look at chest movements. If somebody, as another measure of breathing, we look at chin tone, so many things. And then based on that, we look at the number of times they stop breathing or reduce their breathing, and you get a number called the AHI, apnea-hypopnea index, which is a measure of the severity of somebody's sleep apnea. And then based on that, we grade mild, moderate, severe. There are in other provinces options to do a home sleep apnea test, HSAT. We generally don't do those in Ontario because they don't qualify for OHIP funding of CPAP. So if somebody gets a home sleep apnea test, they know they have sleep apnea, they still can't really access the treatment. So that's an ongoing area of advocacy. I won't get into that. But so you might hear about if you have a friend or family member in another province, they've done the test at home. We don't really offer that in Ontario. In Ontario, to get a diagnosis, if you're concerned, you need to get a sleep study and see a sleep physician.
Wonderful. I just want to keep going, so Herman, you're going to have to control me and let me know when I need to stop asking questions. How do vitamin deficiencies, for example, vitamin D, magnesium, affect sleep?
So magnesium is a bit of a challenging one. There's not great evidence as far as I know for that. Sometimes it can be associated with restless legs or other things like migraine, but less about the deficiency and more about we know that if we supplement it, it can sometimes help. Vitamin D is a little bit more challenging. As you may know, vitamin D has a huge spectrum of the ways that it affects the body. And in some cases, it's a direct effect. And in some cases, it's a signaler of something underlying going on. Occasionally, patients will present with substantial daytime fatigue or sleepiness that is related to vitamin D deficiency. In Canada, most of us are vitamin D deficient just by nature of how much of our northern latitude and how much light we get. And so oftentimes in people who have unexplained fatigue, if there's no other explanation based on sleep test, blood work, etc., supplementing vitamin D is a reasonable trial.
Wonderful. The test can certainly be at the sleep labs, very, very helpful. Somebody wants to know if wearing a sleep mask is problematic. It helps to sleep at the length of time that is mentioned. Like, what should they do with a sleep mask?
Yeah, like an eye sleep mask covering the eyes.
I believe so, yes.
Yeah, there's really good evidence that light exposure, even really dim light, worsens sleep architecture. So blacking out light improves sleep quality. Often the best way to do that is with proper blackout curtains. But if that's not possible, a sleep mask is great. Just be careful of one. Some will push on the eyes, and that can be a little bit damaging. So they make some nice ones that that kind of go around the eyes, and they create a nice seal in darkness. So yeah, if somebody can't black out the rooms in other ways, then a sleep mask is a great option.
Someone's asked a question very specific to Alzheimer's. So is it healthy? Oops, the question moved on. Is it healthy for somebody with early stage dementia or just recently diagnosed to be sleeping 12 hours a day?
That's a really challenging one that we see not uncommonly in clinic, is this excessive daytime fatigue that can be associated with neurologic conditions. The first step is to assess for other things that might be making that person sleepy. Alzheimer's in itself, later stage, can really disrupt the sleep and cause sleepiness. Early Alzheimer's, you'd really have to wonder if something else is going on. So that's the situation where speaking with a doctor would be a good idea, to assess for other causes of sleep disturbance and to not simply assume that it is in itself just a sleep problem. Mood disorders are really, really common at the time of diagnosis of mild cognitive impairment and dementia. So that would be one of the big things to think about, as well as sleep disorders like sleep apnea, et cetera. So anyone who's sleeping that much warrants a sleep assessment.
And have direct contact with their family physician for sure. Do e-readers which have dim lighting cause problems for sleep?
Some e-readers are LED lights. So like I think it was is it Kindle Fire, is basically a phone, like it's a tablet. Those have problems because they're that bright light. The e-readers that use I forget what it's, like the false paper where they put the ink on the screen, like Kindles, those ones are okay. There is a night mode where you can warm the light and dim the light and invert the colors. That's the best thing to do to try to limit the amount of light. But in general, e-readers are okay. Just it's best to take some measures to reduce the bright light and the cool light exposure.
Thank you so much for answering these questions. I know there are so many more questions, but we also want to be respectful of everyone's time. I'm sorry if I didn't get to your question. Thank you so much, Dr. Charlesworth. I just want to follow up with you personally. This is so fascinating. And I think you're right. At some point in our lives, we all have trouble sleeping. So there are so many great tips. Thank you very much. And now it's my turn to remind everyone that we have a webinar poll. And I know you're going to rate Dr. Charlesworth fabulous. This was so helpful for all of us. And that we're going to follow up with you with a recording of this evening, because there were so many tips. The first question we would like you to answer is, did you find the information provided today useful? Please answer the question, just yes or no. Do you plan to apply any of today's learning to help you delay or prevent dementia? Yes, no, not sure. I can tell everyone absolutely. I've been taking notes here. Would you recommend this webinar to a friend? Yes, I can say that. That's my answer. But please make sure that you do answer these questions, because it's very helpful to us to plan future sessions as well. So a reminder, we will follow up with another survey. We want to get your input into what we should be discussing next. And we want to remind you about our Dementia Learning Hub as well. If you'll go to our website, dementiahealth.ca, Dementia Learning Hub. I know that I've been looking at it since I joined the Dementia Society 8 months ago, and I'm always learning a little bit more. I can learn at my own pace. It's such helpful information, so please make sure you do look at our website as well. And a reminder that you can find all of our information around the Women's Mind Matters at dementiahealth.ca, Women's Mind Matters, and you'll find this series of webinars that we have hosted. And one last request, if you can, as you know, all of the programs and services that we deliver for caregivers and people living with dementia are delivered at no cost. If you can help us, if you think our work is important, if you can make a contribution, volunteer time, your compassion, your expertise, and a personal one for me, if you know a caregiver that is struggling, or if you know someone living with dementia, please reach out to them and tell them that we're here. It is very important that we reach all caregivers. Every year we serve over 5,000 caregivers, but there are 24,000 people living with dementia in Ottawa and Renfrew County. We need to reach them all, and we need your help in so many ways to do so. You can sign up for our newsletter. We have amazing resources. We encourage you to come visit our center. We have a dedicated staff team, incredibly professional, compassionate, so well-resourced, and they really do provide amazing information. And remember, here at the Dementia Society, no one faces dementia alone. Thank you so much for your participation this evening. Thank you, Dr. Charlesworth, for sharing your expertise and for taking the time to answer all these questions. And we will be forwarding the resources that are shared with us later. On behalf of all of us here at the Dementia Society, thank you for joining us. Un gros merci de notre part. Bonne soirée tout le monde.